Thank you for joining the Chest Wellness webinar for September. The title of this discussion is Taking Care of Your Team During COVID-19. My name is Alex Niven, and I am really looking forward to this conversation with just a fantastic interprofessional panel that we have assembled today. We have a few administrative notes that we would like to cover before we get started. Next slide, please. So I want to highlight for everyone who's joined us today the Chest Wellness Center, which is available. This is an image on the slide, and if you could take a phone, you can scan the QR code that's in the bottom left corner of the screen to go directly there. This Wellness Center includes recordings of all the webinar series that we have put together for this initiative, along with a variety of curated resources that we hope healthcare providers will find helpful as they deal with the challenges of COVID-19. Next slide, please. As I mentioned, this is a wellness webinar series, and so we started this initiative in July, talking about the importance of a deliberate approach to high performance, and in August talked about specific individual tactics to maximize our performance, both for ourselves and our patients. Today we're talking about our team, and in November and December we're going to talk about organizational approaches to resilience and mindset considerations. Next slide. So again, my name is Alex Niven. I'm a consultant in pulmonary and critical care medicine at Mayo Clinic and the chair of this wellness initiative. And I'm just going to have the other individuals on our panel introduce themselves as we go through this next series of slides. Joe, can you go next?
Hi, good afternoon, everyone. My name is Joe Falise. I am the nurse manager for the CV ICU and Neuro ICU, and most recently the COVID ICU and the University of Miami Hospital and Clinics.
Thanks so much, Joe. Kathy?
Good afternoon. My name is Kathy Fedor. I'm a registered respiratory therapist. I am a clinical manager for the Pediatric Respiratory Therapy Department at Cleveland Clinic in Cleveland, Ohio. I'm also the president of the National Board for Respiratory Care, and I'm happy to join you today.
Thank you so much, Kathy. Julie?
Good afternoon, everyone. I'm Julie Jackson. I am the manager for Respiratory Care and ECLS services at Unity Point Health, Des Moines in Des Moines, Iowa.
Welcome, Julie. Carl?
Thank you for the invitation. I'm Carl Kaplan. I'm the chair of the Chest Respiratory Care Steering Committee, and I'm currently working with Kathy on the Board of Trustees for the National Board of Respiratory Care. And I'm a pulmonary critical care physician.
Along with many, many other responsibilities, Carl. Geneva?
Hi, good afternoon, everyone. I'm Geneva Tatem. I am an associate professor of medicine at Wayne State University School of Medicine and the fellowship program director of pulmonary and critical care medicine at Henry Ford Hospital.
Thanks, Geneva. Joanne?
Hey, everyone. Excited to be part of this panel. I am Joanne Wozniak, and I am the lead advanced practitioner for the pulmonary and critical care team at Leahy Hospital and Medical Center in the Metro Boston area.
And James.
Hi, everybody. Thanks for the invitation. My name is James Town. I'm an assistant professor of medicine in the Division of Pulmonary Critical Care and Sleep Medicine at the University of Washington, and I'm the director of the medical ICU at Harborview Medical Center.
Well, welcome all, and really excited about our discussion today. This is our disclosure slide with regards to conflicts of interest. And if we move on to the next slide, just a few housekeeping tips before we start. So this activity is accredited for CME credit, along with both nursing, nurse practitioner, PA, and respiratory therapy credit. And so the instructions in terms of how to gain credit is there and also was sent to you as part of the registration for this webinar. And again, this is the methods to claim credit for this activity. And I believe that is our last slide. And so with that, we will start this conversation. So welcome to the September edition of our Chest Wellness webinar series. And our topic today, again, is taking care of the team during COVID-19. I don't think I need to tell either the panelists or the attendees just how much COVID-19 has disrupted our daily practice, both personally and professionally, since the onset of this infection and the challenging impact that it has created globally. We know that teamwork is an essential component of any high-performing healthcare environment and has been an important factor to help manage the challenges and additional workloads that we faced caring for patients with COVID-19. Our teams have been under now considerable stress for an extended period of time, and strategies to support and sustain these team members' performance has been a growing concern, certainly at my institution, and I suspect in many others across the country. Many healthcare systems have been forced to augment staffing with individuals without formal critical care training during times of increased ICU surge capacity, and have faced the challenge on how best to prepare and integrate these individuals into their unit organization and culture. And so really, how to sustain our teams and how to prepare individuals who don't traditionally work with our teams to best integrate themselves with our clinical environment so that we continue to maintain the best clinical setting to take care of our patients is the challenge that we face today. So what I'd like to do is start by drawing from this distinguished faculty a little bit of their past experiences in terms of the challenges that they faced over the course of the pandemic in their individual practice settings. And see if we can identify some of the key lessons learned that we need to think about as we prepare for the winter ahead, which I think all of us recognize is potentially going to be a challenging one. So I guess I'd like to start with James. So James is from Harborview in Seattle, and was really at the tip of the spear when it came to dealing with COVID patients and putting together an environment that supported a team during a very challenging start to the global pandemic in the United States. So, James, I want to put you on the spot a little bit and just tell us a little bit about your initial experience and the things that you all worked together to do as a team.
Yeah, I mean, thank you for the question. I was just reflecting on how much things have changed since back then. Our first patient in Harborview was identified in the last week of February, actually. So it's really before we were all prepared to take care of COVID patients. Our infection control team had been thinking about this for a month or so, just based on reports out of China. But pretty quickly, we had to mobilize a different ICU, which was normally our neuro ICU, and sort of augment the physical structure to accommodate more negative airflow. And we, have an older hospital, so it wasn't really used to that kind of change in the HVAC system. And in addition to that, I think, everyone, I think, had nursing, respiratory therapy physicians. We all were stunned by just, the change to the workflow around the system at the outset where, elective surgeries and things were canceled and there was, reduction in visitors in the hospital. And also, but, like you said, being at the tip of the spear in a way that it was our job and our duty to take care of those patients. And that's why we had all this resources and infrastructure built up. So I think it was a real mixed bag of emotions for people, just, facing something that was new and unknown and surprising, but at the same time, I think we all recognized was our duty to be in that position. So I think a lot of, the development of camaraderie and spirit happened around that time was, at the outset where we said, okay, we're all going to take this challenge on together and we're going to work together, and we know we're not going to be perfect, but we're going to adapt as a team. So I think that spirit, I would say, was one of the things that got us through those most difficult periods.
Something that I'm regularly reminded every time that I'm in the ICU is that for every 5 minutes that I spend at a COVID patient's bedside, I have a bedside ICU nurse who is spending hours, literally, compared to my 5 minutes, and respiratory therapists that also are spending much, much more time and therefore are likely more impacted by the personal protective equipment and all the challenges that come with COVID patients. I want to turn perhaps to Kathy and then to Joe and Julie to maybe talk a little bit about how that experience has been for them and the people that they've worked with.
Well, I think, one of the biggest things was that in our ICU, all the RTs and the physicians and the nurses all had a buddy. And that buddy was responsible for making sure that donning and doffing was done correctly, first of all, so that you always made sure that you were always safe. The other thing that we did was we got quite innovative in our techniques about how we set up our rooms. Our patients went in feet first sometimes so that we could separate our ventilators and our screens. And the IV pumps were outside the room so that we could minimize the number of times that we went into the room and use less PPE and protective equipment. That was not unheard of. I think in burn units, that they actually separate the ventilators and the screens quite often. Most of our institutions, we're a 12 hospital system, and most of our ventilators are servo ventilators, so they have 12 feet of cable already, or 7 feet of cable, I should say, already on them. And so you can separate them quite easily. The trick was to put the screen on a stable mount so that they didn't fall off and shatter. So that was important. In terms of the IV pumps, it was really a matter of trying it, testing it, and using it, making sure that it worked safely. So that was kind of how that process went along, because the thought process behind it was, if you went in and made a rate change based on a blood gas and maybe you forgot to adjust the ventilator alarm, having to don and doff just to go in and change an alarm system was another repeated exposure. So, it was felt that this was really not only a caregiver satisfier, but it was also an important safety feature that we were able to do in order to make sure that people had less exposure to COVID in and of itself. On top of that, we did a lot of education for all of our staff, and it allowed us to respond to alarms that were appropriate, knowing that we didn't have to go in the room every single time something alarmed. We knew when IV pumps were running low. We knew when ventilators could be troubleshot from outside the room rather than inside the room. So it made better use of our resources. I think, we had daily COVID calls. So we, as everyone knows, things changed extremely rapidly over time, especially in the beginning. So it allowed us to, kind of communicate those changes on a really rapid basis. And so I think that was really, really important because we translated all of those daily COVID calls into a written document that lived on our intranet. And then we had a My Learning module that was kind of in our computerized learning program that everybody could log on to. They could either participate live on the weekly presentations, or they could actually log on and do it when they had time. So, it gave us the opportunity to educate everybody equally. So.
Some incredibly innovative solutions to a very challenging situation. There was a question in the chat box with regards to if there's any published data in terms of morbidity or mortality associated with healthcare providers caring for COVID-19 patients. I'm actually not aware of anything to that effect, although Julie, could I turn to you for a second to ask about the wall that the ARC has commemorating individuals who have basically died related to COVID-19 in their service?
Sure. So the AARC has put together a virtual memorial. So that is an area where respiratory therapists or anybody can donate to. And what we're trying to do is get the names of all the respiratory therapists in the country, regardless if they're a member or not a member, so that we can honor them as respiratory therapists for their service during this COVID time. So that is out there on the AARC's website. Anybody can access that. You don't have to be a member to do that. And I know that a lot of us in our state societies have pushed that information out as well, because it is really hard to capture from the AARC standpoint who has all been affected by this around the country. We know that therapists have, but we don't always hear about it. And it's nice for some of us as well. Like in my local facility, one of the things that we did is every time we could figure out that there was a therapist that might have passed away, we did a concerted effort here to send a sympathy card. We all signed it from our department and sent at least a sympathy card saying we were thinking of you in your department, you know, but not always knowing. So that wall is helpful too, because when we want to reach out and make sure we're capturing everybody from our department perspective too.
Well, thanks, Julie. Joe, give us some perspective from a nursing standpoint.
Sure. Thank you for the question. I think what's most interesting to me is the power of intuition, because as I listen to other stories, I think, wow, we had something very similar, and there's really been no book on how to do this. And I think that's what's made me so proud to be in this profession right now, is because although we had a very challenging situation, I think we all kind of pulled together and made it happen. But anyways, from a nursing perspective, you know, to say that I'm extremely proud of our team and our organization for handling this the way we did would be an understatement. Right from the get-go, we had a little bit more time, and I say like a few days more time, to kind of see it coming a little bit. So, you know, we were planning a long time before it actually arrived here. But I think that, again, as Kathy said, I think we were very innovative in our approach. We quickly understood that our normal ICUs may not be the right place to take care of these patients, because we do have some limitations as far as negative pressure. So, you know, in working with our mechanics and our engineers, we were able to take multiple med-surg units and transition them to negative pressure units. The whole unit was negative pressure. And then we kind of closed them all in, and, you know, as we were taking care of patients, the nurses and the doctors, everybody be in there at the same time, and the therapists. And again, we created that, what we called a trained observer. That's what we called it. And that observer was somebody who stood in our anteroom. So instead of an anteroom for every room, we had an anteroom for the whole entire hallway. And that hallway, basically, when you came out or into that hallway, that observer was there to watch you. So that was typically always a nurse. And it was really collaborative on our part, I think, to see even physicians and support staff, therapists, nurses, all of and housekeeping, even physical therapy. Everybody who had to go see patients, you know, was able to work with this observer and respect that position to the point where they were there to help you. And a lot of our effort really focused around that, what happened in that anteroom. And making sure that we were donning it properly, and of course specifically when we doffed it, and I really feel like nursing really worked collaboratively with everybody to make sure that our process was solid, and that once we had a plan in place, everybody was able to follow it. And you know, we just kept listening to the staff. What makes you feel uncomfortable? What makes you feel comfortable? What can we make better? What do we need to start over with? Having routine meetings, routine discussions, daily 3 p.m. calls with administration about what support did we need? What could we back off on? What do we need to change? So just a lot of pieces of the puzzle. And I'm proud to say that nursing and respiratory was never left out of the loop when it came time to make important decisions, right from the very beginning.
So I hear common themes of lots of communication, collaboration, innovation and support, both personally and also maintaining consistency with the new and novel practices that we had. I want to turn a little bit to Geneva and Joanne before we move back and talk about how we were able to implement some of the successful things that we were, because we all recognize that in addition to physicians and nurses and respiratory therapists, advanced practice providers have shouldered a substantial burden when it comes to the care of patients in the ICU with COVID-19. And especially in our academic and teaching institutions, most of that point of care is delivered by fellows and residents. And so I think those are two very unique perspectives we need to bring out. So maybe I'll turn to Joanne first to talk a little bit about some of the challenges that she faced in her hospital with regards to the APP practice and supporting the care of patients with COVID-19. And then Geneva to talk a little bit about her experiences as a program director at Henry Ford. Joanne?
Thanks so much, Alex. And much like our colleagues have talked about from respiratory therapy standpoint and nursing standpoint, the advanced practice providers worked collaboratively with all of the team members, the physicians, RTs, nurses. And in our institution, our APPs are at our peak of COVID, there's a bunch of 13 strong, exceptional critical care providers, and they went above and beyond. Our unit, it was a 12-bed unit. We saw so many COVID patients that we flipped into a bigger unit. And then from that unit, we went to a second, a third, a fourth. And as the units opened, the APPs team that normally worked together side by side split up, and each AP went into each of the different units to lead the others within those units in critical care that they may normally not have done since med school or since residency. So the way Leahy staffed the units were with one skilled critical care provider and then with support providers. And those came from all over the institution, from surgeons, attending anesthesiologists, attending nephrologists, and residents and fellows. And we all worked together. And I'm so proud of our APP team as they led the charge in ARDS management and all the initiatives that we needed to do as we were taking care of the COVID team. Some of the struggles that they faced were how quickly we expanded and how quickly we needed to teach the non-critical care providers critical care. You needed to learn pretty complicated vent management, shock management very quickly. And the burden, a lot of it fell to the APP team to teach all of our providers these initiatives. Hearing the difficulties that we had during that time and how quickly we expanded, we have started training a reservist program in preparation for potentially a second wave and a second surge, gosh forbid if it were to come in the coming months. And we have another fantastic group of advanced practitioners from Leahy from all different backgrounds that have stepped up and volunteered to learn critical care, albeit very quickly, but we are having them work with us side by side in the unit, taking patients, rounding. They attend a course that Leahy is paying for virtually to learn critical care, and then work with us in the unit for 5 shifts, and then coming back for refreshers to, if, gosh forbid, we did surge, they'd be called upon and would be deployed to our ICUs to work side by side with the critical care providers. So it's pretty amazing to see everybody, much like Joe said and everybody else has been saying, the collaboration and the teamwork that COVID brought out. It's definitely been a very tough time, but everybody has stepped up across the system and just want to do the right thing for the patients and each other as well. So it's been tough, but they're an amazing bunch at Leahy. Selfishly, I will do a little shout out for them, but it's great to see everybody else stepping up as well and working on this program.
Yeah, no, that sounds like an amazing and well-organized program. Geneva, how did you approach things at Henry Ford in terms of supporting your trainees?
Yeah, I think there were manifold issues to address as, a program director in terms of team leadership and team structure. We found at the peak of our surge, we doubled our ICU capacity from about 68 medical ICU beds to over 120 medical ICU beds in about a week. And so that required us to do an enormous amount of team coordination and team organization. And so about the second or third week into our surge, we declared an emergency categorization by the ACGME, which basically alerts them that there's, substantial and sustained disruptions in programs across the entire hospital. And so with that emergency categorization, we were able to reconfigure our ICU teams and make sure that we had both a horizontal and vertical deployment. So that way we could get trainees from other programs, residents from other programs to deploy into our ICUs. We developed a platoon system very early on. So for my fellows, our pulmonary and our critical care fellows, we developed sort of a backup platoon, if you will, so that we deployed them into our ICUs at night. And then we had a separate platoon that would rotate on 2-week blocks into the ICU and out so that they could get proper rest, proper downtime away from clinical activity within the hospital, and also be a backup platoon for those fellows who were actively deployed into the hospital in case we had additional needs. And so this was a learning process as we were doing it, just like everyone else, because we, obviously at the outset didn't know how many of our trainees would potentially be exposed or how many of our faculty would be. So developing that platoon system very early on was incredibly important. And as the surge continued, it became important to work across both residency and fellowship programs in terms of prioritizing the things that are important to us in the academic world, particularly when we look at work hour requirements, making sure, again, that we were all in compliance with those work hours, and made sure that residents and fellows who were deployed from other programs, that their program directors were reassured that was a priority for us. Because again, it was incredibly important to make sure that we were mindful of the overall well-being of all of our trainees deployed throughout the hospital. And so making sure that we kept a close watch on how frequently they were being called in to take care of these patients and what the overall workload was for them was incredibly important. And I think also, having the proper resources, it cannot be underestimated and underemphasized. The importance of making sure that our trainees had proper PPE, but not only had the physical equipment, but had the ability to train on how to don and doff. It seems easy to us now because we've been doing it for months on end, but really helping them do that process safely so that they could protect their patients, protect themselves, and protect their team members was a key step for that. And I think that was an important step for them in order to make sure that they didn't assume unnecessary risk by not having the resources and the training that they needed to take proper care of their patients.
Oh, so that's fantastic. So trying to summarize what I think is already a long list of take-home points from this. So early in the pandemic, there was a huge sense of challenge, and I think that drove a lot of camaraderie and collaboration as we adapted to new systems and processes, spent considerable time putting together resources to help train and strengthen our teams, and also looked creatively at ways to staff, significant increased load. I think that Geneva has started to touch on something that I really wanted to delve a little bit deeper into, which is, as the months go on, I know that my teams have started to get tired, and thinking about deliberate approaches to support those teams who have been working really hard for a really long period of time is something that has been an increasing concern at our institution. And then the second part is recognizing the rapidity with which we had to scale, more ICU beds with potentially non-traditional staff. Joanne has already talked a little bit about, one way to sustain a reserve group to potentially rise to meet the next surge. And I wanted to pose that question to the group a little bit in terms of more detail and lessons learned, both in terms of processes and procedures. And Kathy, there's also a question in the chat box with regards to the remote monitoring techniques that you all employed at Cleveland Clinic. But before we move into that, I wanted to turn a little bit to Carl, because Carl is unique from the standpoint that he has volunteered to serve as a locums in a variety of surge areas over the course of the pandemic. And I think probably has some unique perspectives from the end user standpoint, what it's like to step into a new environment with a group of people you haven't worked with before and deal with what we all know is still a very challenging group of patients to care for. So, Carl?
Well, thank you, Alex. That's a difficult thing to address because every institution is vastly different. Every culture is vastly different. Every design, their resources, the mechanical things they have, whether they do have potentials for remote monitoring, if they had only 100% LTV ventilators, taking care of the sickest of sick patients. So it's very hard to compare one versus the other. But the most unique and rewarding was my experience in March and April in New York City. Because it's not that they had to ramp up to a virtually 100% census of nearly almost everybody in the hospital was ICU candidates and related to COVID, but it was also the uniqueness of the behaviors to develop immediate functional teams, not only for people that were already in the system, from anywhere from the elevator operator to the runners running back and forth with lab specimens, the residents, the fellows, the nurses, the PAs were outstanding. But it's also the fact that it was like an all-star game where we had physicians coming in from University of California, San Francisco, from Cleveland Clinic, from Intermountain, from Utah. So we had outstanding people coming from different places with their own backgrounds and cultures within their organizations and strengths. And they had to immediately adapt, and they had to immediately form the teams. And I took over 3 teams at 3 different times when I was there. And I have to say, I thought it was only because I'm from New York that I was able to do it. Unfortunately, I have a very strong accent that never left me, so they knew where I was from, so they were familiar with my communication skills. But also the fact that people adapted immediately. It was almost like what I say is a choose-up game of basketball or baseball or soccer in any particular field. People immediately knew to stay on the court, they had to play together. They had a purpose to win, and they had to not show off because they knew if they lost, they were off the field and there was no chance for that day to play anymore. So it was just an incredible privilege working with incredible clinicians, whether from every level, that immediately adapted. And I was very impressed, not that I'm anybody of anything of worthy, but I was immediately apt to identify myself and recognize every member of my team and very large teams. And the respect and coordination was almost immediate. And the people were able to adapt. And whether it was a resident functioning as a fellow functioning as an attending, nurses and therapists exceeding their scope of practice in every possible way for the better good of the patient. It was the best experience of my whole life. It's like going to a concert. If you weren't there, there's no way to describe it. But that was unique for this academic center that actually 45 years ago, I was a volunteer. It was an old Salvation Army academic facility that got me to leave my PhD, that got me to leave veterinary school and go into human practice, because it's that same thing. It was the community, it was the patients all working together, people bringing in meals from different organizations, bringing food 24 hours a day. Everybody in the community wanted to participate. So it wasn't just a collective entity with respect to the respectful working together collaboratively as clinicians, but it was the larger community that was also involved. So that was very different, though, when I went to different regions of the country, because they had more time to ramp up, but at the same time they were overloaded, and each one addressed the magnitude of patients having to be transported out, and sometimes hundreds at a time. The thing that I just want to give a shout out that I don't think anybody's mentioned to, when I had the privilege of working alongside the National Guard, I mean, we all recognize the PAs, the nurses, everybody, dietitians, physical therapists, you name it, everybody was giving patients care. But the incredible people in each state, the National Guard, that ramped up immediately and had to engage into systems that they also never worked before. And they worked parallel. They had uniformity, they had consistency, and I was overwhelming. If I had to remember one important thing that was the most valuable experience for me outside of the New York City experience, was working alongside the National Guard. And again, I don't think they get enough recognition of what they offer their states, their regions, and the country. Incredible clinicians, both nurses, technicians, therapists, and physicians. So it was hard to find a commonality. The easiest things was the patient. We were focused on the patient. The contrast, unfortunately, is when systems now, late in the game, are trying to ramp up their economic necessities and their routine practices, trying to maintain their history and to maintain their financial viability. But it's, and that sometimes is in conflict with regards to the COVID mission. I wouldn't say conflict in terms of contradictory, but challenging to have them parallel together.
Yeah, yeah.
I'm not sure if I addressed what you were hoping from me.
No, I think that's perfect, Carl, because I think it gives us, I think, a very different perspective. You know, most of us have worked in our own institutions in sort of very unusual circumstances. You have taken that experience one step further in terms of moving through a variety of different institutions, working with different people in different areas. So what I'd like to get to in the last now 20 minutes that we have is thinking a little bit about how we draw from these lessons and apply them to potentially the challenges ahead. You know, we're all concerned about what's going to happen this fall and winter in terms of a second wave. And you know, I forget now who said this, but you know, we had very similar monitoring systems to what Joe had described with regards to PPE adherence. And we had tremendous focus in terms of our planning and preparation and communication of our novel processes. But as time goes on, the novelty starts to fade. And maintaining adherence to those best practices and also supporting the team that has been under a great deal of stress now for months on end represent, I think, two big challenges for our managers. So I guess I'll turn to Geneva just to ask the second question first and give the rest of the panel a chance to think about the first. How are you monitoring your teams, house staff, and other members in the unit right now to find out how they are doing on a regular basis and identifying opportunities for support? And then I think we'll move back to the second question after that, and I'll open it to anybody in terms of how we're drawing from your experiences to make sure that that planning and preparation and the fine-tuning that you have stays as strong as it can be for the months ahead. Geneva?
Thanks. I think, you know, both situational awareness, having an understanding of what's going on around us, as well as situational monitoring, you know, which is sort of assessing to gain an understanding of what's happening are two things that we've continued to do, not only throughout the pandemic, but certainly in this post phase. And so we've spent a lot of time, particularly with our residents and fellows, monitoring them and really getting an understanding to what's integral to their wellness. You know, we've set up peer-to-peer groups. We've done a lot of walk rounds in the intensive care unit to make sure that whatever it is that they might have or need gets identified. and also making sure that what they've needed in terms of task assistance was there. You know, they did a yeoman's job throughout the entire pandemic and continue to do. In fact, our health system's response could not have been as outstanding as it was had it not been for the efforts of our residents and fellows within the organization. And I think that is well recognized and well appreciated. And I owe a great debt to them for everything that they've done. I think they really spent a lot of time protecting each other from work overload, which I think was incredibly important. You know, it's different from a program director standpoint to try to mitigate that overload, but to have their own peers make sure that they had each other's back and really took good care of those issues was incredibly important. And everything that they requested or needed was really within the context of providing safe care for their patients. It was never in the context of just taking care of themselves, which I think was incredibly important. So making sure that we as leaders within the health system could really make sure that the environment was psychologically safe for them so they could ask for what they needed and know that whatever it was that they needed to make their care safe would be given to them was incredibly important. And so those are the things that we continue to do as we move forward. And that's an integral part of our next surge plan, if you will. From a GME standpoint, we've collected all of this information and we've used it to create a surge plan for the next wave so that we can be a bit more facile in these team building issues as we come across the next wave that we're bound to face.
To piggyback a little bit on what Geneva was saying, the big thing that I've learned from my own experiences with the advanced practitioner team is checking in a little bit more. How are you doing? The situational awareness that she was talking about, mutual situational awareness. And, you know, you think that we as critical care providers are tough. We're type A personalities. We are headstrong. Everybody's going to be fine. But understanding that the emotional, the mental, it takes a big toll on our providers, and checking in a little bit more, checking in on each other. I think going into a possible next surge is a big thing I've taken away. One of my team members even suggested asking everybody to look out for each other, and if they notice someone has a bad day, reaching out to me, and maybe I can get them a day off the next day if it was, you know, a little bit to help from that standpoint. So I think, you know, really looking out for each other as much as everybody worked together and how hard they worked, being sure that everybody is okay in the end is something we need to do for everyone. In our institution, our behavioral health program and psychiatry have started a program of more formalized sessions with providers, with staff across the board to offer that support as well. So I think what Geneva was saying was a fantastic point to bring up.
This is Julie. I'm going to piggyback a little bit too on that. So, you know, we've recognized over the course of the last few weeks here at our institution that there's, I don't really want to call it burnout, but just, you know, a stress and fatigue happening, and knowing that we're going to be going into the next, whatever the fall is going to bring, let's just put it that way. Anyway, so what we've done at our organization is we have taken a look at, okay, do we need to keep all these patients still cohorted? Can we move them to their regular floors? So for example, if they came in for a surgical procedure and they ended up testing positive, do they need to go back to the surgical floor, or do they really need to go to the COVID floor? What we're seeing is a lot of our nursing and our RT staff are, you know, worn out. So we're working on trying to figure out a way to not cohort them, spread the wealth, for lack of a better word, a little bit, making sure we have all the, everyone trained. The goal for us would be, you know, by Thanksgiving time, everyone can basically take care of a COVID patient anywhere in our organization to kind of, you know, spread that out a little bit. The other thing that we're really doing is trying to put some fun back into what we all do. You know, prior to COVID, I'm sure we all had, you know, things that we could go out and do as teams. We could be outside the hospital doing things as teams because we didn't have to worry about the social distancing. We didn't have to worry about some of that stuff that's going on currently. So what we're trying to do is find ways to still do fun things here at work. For example, today we had a salsa eating contest. Some people made salsa, and we had a contest with the ICU teams and the RT teams, and we had our pulmonologists who are intensivists. They picked who had the best salsa. You know, just little things like that. Here, I'm in Iowa, and so one of the big things here in Iowa is the state fair, and that obviously was canceled for pretty obvious reasons. But so with that, we recognize that a lot of our staff would miss out on that. So our ICU teams and our respiratory teams, along with our physicians, we got together and we hosted kind of a carnival type of thing within the organization, within following social distancing and all that. And we even had physicians who were willing to get in a dunk tank so that the nurses and the therapists could just take out their frustration they might have by dunking their favorite doctor in the dunk tank, you know, just things like that. We're just trying to find things that we can do to continue to bring down stress. And then also looking at, you know, systems we have in place with our employee assistance programs. You know, our wellness teams here have come, at least with the RTs, and done some stress management strategies. We've worked with our pastoral care services to just make sure that they have the opportunity, if they want to go to the chapel and have a session to kind of get some frustration out or talk about a bad situation, they're able to do that. So those are some of the things that we've been doing here that can happen here at the organization that then also could carry over to their home life, because that's the other thing. Usually your home life is where you can get away from everything, but when you can't go out and do some of the things you typically would do to relieve that stress, it is more difficult. So.
Joe, did you want to go next?
Sure. So I'd like to just add a couple of things. And I think for me, you know, supporting the staff, for me, I really kind of focus on probably three different areas. The first area that I'd like to talk about real quickly is just, I think there needs to be consistent and committed leadership. I think that a lot of the staff buy into the leader and the ability to convince them and give confidence and gain their confidence. So one of the things that I think is special about our organization is everybody from the top down, our CEO, COO, everybody really, our CMO, we really have a vision. We had a vision all along. We've somehow created that vision, and I think everybody has bought into it, given our ability to combat this as a team. So I think one thing is, and although our census is somewhat stable right now, you know, and although we're not ready to exhale just yet, because everybody's looking forward to the projections, and we want to make sure that the staff know that we're not letting up. We're not taking our foot off the gas here. We're making sure that they are our priority. We are, you know, making sure that we still maintain that discussion around making sure that we have PPE. We're looking for process improvement. I think that's probably another thing is, while we have a little bit of time right now, we are committed, and we want to be very transparent and clear with the staff to make sure they know what we're doing, why we're doing it. We're you know, moving people around a little bit so we can decontaminate hallways, open things up, and try to get everything cleaned again, using this opportunity to optimize what supplies we might need in the future, and helping them to understand that we're here to help them do their job better. Listening to what they're saying, I think that's a big one. Keep our ears open, listen to what they're saying, tell us what works and what doesn't work, so we can try to help them. And then the last thing is, you know, when we had our first surge here in Miami, we've kind of had two surges: the first surge and then the post Memorial Day surge. I think the first surge, we did a great job of a lot of community involvement. We had, you know, the fire and the police parades. We had athletic teams who wanted to, you know, Zoom with all of our staff members. We had a lot of really fun things to kind of take our mind off a little bit. And then in our second phase, we didn't really, you know, some of that has started to die down, and we've now started to set into the mindset like, this is really a marathon, and it's not a sprint, and it's not going to go away. So we just want to make sure that we stay committed to the staff. And then my real third focus is really on making sure that we stay committed to having good staffing. Understanding that if another surge hits, we've got to have enough nurses, enough physicians. We've got to have all these protocols in place and just stick to them. Staying the course and making sure that, because unfortunately right now we're staffed with a fair amount of traveler and agency nurses. And other staff as well, other agency respiratory therapists and things like that. We need to stay committed, and our senior leadership has told me time and time again, we'll take it on the chin, we'll keep them here because we don't want to take a chance that we're stuck without staff when the next phase hits. And I think that goes a long way to letting the staff know that, that we are supportive of them and that we're trying our best to provide an environment where they can, not get overwhelmed as much as possible.
So I'm hearing the key is to make sure that we support our people, make sure that they have the resources that they can do their job safely and effectively, and that we're thoughtful in terms of making sure that they have both peer support, time outside of work to recover, and from a management standpoint, we need to listen, think creatively about ways to improve our system to make their jobs easier to do so that we can take better care of our patients. Let's keep that discussion going. Kathy, I think you were next.
Yeah. So I think, our COVID surge plan was always built so that it could be versatile, so that if we ramp down, we could always ramp up at any point. And that could be anywhere at any point within the surge program and plan itself. So I think we're well suited to do that. But I think also, because we've been kind of on the downside of things for a while, we don't want people to lose those skills. So actually all of our mock codes and the mock simulations have been COVID related. So they're all mock COVID patients. Every one of our simulation and mock codes are COVID related right now. So it's just to keep everybody in the same mindset, because I know as a respiratory therapist, my first instinct when I run into a room of a code patient is to want to bag them. And obviously that's not what we do in a COVID patient. So we're just kind of keeping everybody in that correct, kind of chain of events of the things that we should do for our COVID patients, and even transporting them within the hospital from hospital to hospital. The things that we do are very different. So just making sure that we keep those skill sets up. So I think that, just making sure that everybody remembers what they're supposed to do, and making sure that those skills are still in the forefront of their minds is also something that's very important, so that they stay safe. That's another big part of what we're doing right now. And again, we're still in that mindset of supplies. I mean, we're still finding that things like endotracheal tubes are still in short supply. So our supply chain, we're still working really, really hard with them to make sure that we don't run short on those kinds of things. So, and going to the ICUs and giving our therapists, and I'm sure the nurses are doing the same thing, that we're making sure that we give them some relief just from their everyday duties. So that's kind of that's the place where we're at right now in our facility.
No, thanks, Kathy. James and Carl, I think you guys might have the last words here. We've just got 5 minutes left.
Well, I think Joe hit it, how important leadership is, but it's not just the leadership at the top within the organization. It's the team leadership on the ground, at the bedside. You always have to give the respect and recognition of the excellent work that everybody's doing. Mm-hmm. And the other thing, because it was so contagious doing this excellent patient care, that the people didn't realize they were getting fatigued. And no different than a sports team, I had to pull people off, not because they were doing bad work, because they didn't know when it was time they needed a break. So the team leader had to be fully engaged in real time all the time. And I know Julie mentioned how important it was to do things outside the organization for relief and mental relief. But I found it was important also doing this during the day with my team. The two periods of the day that it was the greatest joy in my life in New York City is when these giants would show up, a whole team of giants with Google eyes that were blacked out, Can anybody guess who these people were showing up twice a shift? And they were giants. They were the orthopedic residents that came in to help with proning. And it was just incredible because they were covered from head to toe with Tyvek white. They had their goggles on that were all blacked out. I couldn't see who they were. And it was the greatest joy in the day for me. And I let my team know this was fantastic. But so you needed a break in the monotony of the given day of the stress of the work, not just only after work and the recognition of the fine work they were doing, but you had to find the joy during the day. That was also very helpful. And then obviously debriefing afterwards, if there was a challenging issue or a death of a patient that people worked on for weeks that passed away, no different than we would normally do, to listen. And it was very important to listen to all the team members, because that was really the only time that you realized what was going on, what was on their mind. So listening, team leadership, recognition, and finding any distraction during the day. Again, the greatest memory I have is the giants walking in twice a shift. You never knew who they were because they were covered from head to toe.
James?
I mean, that's such a positive image to end on. I don't know if I want to say anything after that. I think, a lot of people have mentioned checking in with the teams and trying to figure out, what's working, what's not working. And I would say, as a director of the unit, one of the ways that we try to make lemonade out of these lemons is, well, how can we as a system improve and use all those experiences to continue to get better? And how can we apply that to the mission and vision of our hospital? Because I think that's something that we all believe in. But then I think the other thing that, we haven't discussed yet is that a lot of these stressors we're experiencing take place outside the workplace as well. And so I live in Seattle, and, we're a sort of outdoorsy group of people, and we have the worst air quality we've had in, a long time right now. And so it's these stressors that I think are, finding people at home now, that schools are impacted, daycare is impacted, people they know are out of work or being furloughed. There's just a litany of things, and you don't find out about those things until you ask about them. And you may not have a solution for it. Daycare is rough around Seattle, and so we don't have a good solution, but just asking about it and bringing it up is going to help mobilize resources that, if we do have some way to help, that, our institution is starting to try to do that. So I think just recognizing the impact on the whole person and not just the employee or the professional identity of the person is also an important factor here.
Yeah, gosh, I feel like we have covered so much ground over the course of the last now 58 minutes, and yet there's still so much more that we need to talk about in terms of detail behind all the tremendous work and innovation that you all have done in all of your individual facilities. So we're going to try to keep this conversation going in the coming weeks so that we can provide the participants today with more specifics in terms of the efforts that you all are doing in your own individual institutions. I think for right now, I will just bring this a little bit to a close with a few last thoughts. So for me, I think that the COVID pandemic has reminded me very acutely about the importance of teamwork and collaboration to take care of the challenging COVID patients and all of the different sort of new and different problems that we have faced in terms of personal protective equipment, safety, supplies, and dealing with a completely novel infection. For me, I think that, I think that the tremendous work that people have done has been highlighted very nicely in the discussion, over the course of this hour, and really how to sustain that work and carry it forward during the months to come is the biggest challenge, both for our teams that have been doing this day in, day out now for months on end, and also for those individuals we turn to, those giants, to help us during time of need. And as leaders, as managers, I think the biggest challenge is listening, maintaining that impeccable attention to detail that we all started with early in the pandemic with our processes and procedures, the leadership engagements, mutual support and situational awareness that Geneva and so many others were talking about. And keeping that planning and preparedness, at its peak through things like simulation, what Kathy was talking about, through creative, identification of barriers and solutions for those things. I think that's really going to be the challenges ahead. Well, I would love to have everybody sort of give a final 2 words here. I think we're out of time to do that, I'm afraid. But I hope that we will take this opportunity to carry this conversation forward in the weeks to months to come. And I want to thank this group for really an incredible conversation over the course of the last hour. So with that, we'll bring this discussion to a close. Thank you very much for joining us for this month's wellness webinar, and we look forward to seeing you again in the months to come.